And our last topic to make sure we get out on time is pain management. And definitely there's a huge push now with the conservative use of pain medicines, especially opioids, but definitely need to focus on what we can do in the ED to meet our patients' needs, but hopefully not contribute to this problem. So we'll talk about different medicines and different medications and mechanisms of action. And then lastly, talk about some migraine treatments, because that's probably our favorite patient, the migraine patient. How do we treat them without giving in to their desire for something they don't need? So lots of definitions out there, but definitely pain is subjective. It's whatever the patient says it is. And whether you want to go along with the probably the statement that got us here from 10, 15 years ago about it being the fifth vital sign, but definitely pain is subjective, and we have to go with what the patient says it is. Now, there are some objective ways to evaluate this. We may use the FACES pain scale, and sometimes that works just as well for adults as it does for kids. Because some adults, you ask them on that 1 to 10 scale, and they're like, huh? What do you mean? So just show them the pictures and go, which one is you? And that's sometimes a little better than the number scale for your adults. But we have the FLAC scale that we sometimes use for neonates and infants. And we're just looking to see how irritable they look and how they respond to stimulus. We have this now adult nonverbal pain scale that gives us an objective way to evaluate for pain in the patient who can't talk to us. The patient says they have a 10 out of 10 pain, but I might use this to justify my treatment plan because what I observed objectively didn't equal a 10. There's a behavioral pain scale that's out there. These are just evidence-based tools to help guide us in our care. And there's the critical care observation tool, very similar to the FLAC. So the intubated patient or the patient we've got sedated may help guide us in meeting their pain needs as well. There's several things out there. There's just a couple of them that may help us properly manage these patients. The World Health Organization has issued this ladder here, the focus of thinking about non-opioids, maybe some non-steroidal anti-inflammatories or other non-opioids, and then maybe we should stair-step up. Now, definitely if we've got traumatic pain in the ED, significant injuries, we're going to treat those with appropriate management, but think about the risk and benefits. Think about shortest duration of therapy, and that probably we should not be combining opioids and benzodiazepines. That's a big thing they're looking at. So it's important to understand the difference between tolerance and addiction. Most of these opioids, like the benzos earlier, cause significant tolerance. That is not the same as addiction. So with tolerance, I've noticed that I'm getting less side effects, but I'm also getting less benefit. That's just tolerance. And probably most people over about 2 or 3 weeks will notice some tolerance to these opioids. But I'm not addicted to them. I'm not dependent upon them. If you stop giving them to me, I don't have withdrawal symptoms. One thing that may help us with this is rotation systems. And we do that sometimes with our chronic pain patients, or especially our palliative care patients. We'll use one opioid for a month, and then we switch to something else. And that may help prevent some of this tolerance. But it just has to do with something with the receptors. We probably had some decoupling or some changes with the receptors and how well that receptor responds and gives us the agonistic effect. Where dependence is when the patient has to have that drug to maintain normal function. Without that drug, the patient experiences withdrawal symptoms. Tolerance doesn't have that, dependence does. And that's when they experience this abstinence syndrome. And usually after about 2 to 3 weeks, that risk is there, and we know these medicines are highly addictive. During the abstinence syndrome, they're diaphoretic, they have tachycardia, they get a lot of GI distress, abdominal pain, cramping, sometimes vomiting and diarrhea. The lacrimation's common, the yawning is really common. You walk in, they look like they've got goosebumps everywhere. That definitely may be something we see with opioid withdrawal symptoms as well. And just understanding, especially with patients that are tolerant, they're not necessarily dependent, and trying to get them to understand that. But with addiction, patients are seeking out these opioids for their abuse despite the adverse effects they may get with it. And they're using this for their own purpose to get the benefit feeling of the euphoria, the feel-good off of them, despite the adverse effects, despite also the societal complications that we'll see with that. But we do occasionally see people that have this pseudo-addiction. And this is usually on the inpatient world, but these are your clock watchers. These are your patients who are afraid of pain. And a lot of us may have never had to experience severe pain, and hopefully we don't. But these people are clock watching because they've had pain and they don't want to experience it again. As they recover from their surgery, from their trauma, the pain goes away, their desire for pain medicine goes away. These are your patients like, hey, my pain pill is due in 5 minutes. It's because they don't want to experience pain. It's probably not an addiction property. And as they recover, their need for pain medicine goes away. Most of us don't deal with that in the ED because this is an inpatient problem, but we occasionally do see people that have this pseudo-addiction. They're afraid of what might happen if they don't get their pain medicine. So definitely if we're doing opioid prescribing, we definitely need to screen for abuse. Think about what patients or what risk factors may increase the risk of abuse. Definitely use your prescribing monitoring databases that are out there. Most states have rules that say, hey, if you're prescribing more than this many days of opioids, you've got to reflect upon it. In the ED, I almost do it for everybody just to kind of get an idea because they often don't tell me the truth. But there are some screening tools out there, and this is one of them, the opioid risk tool, that kind of helps me gauge if this person's high risk or not. Things we're looking for is mental illness, other addictive properties. If they're a heavy cigarette smoker, they're an alcoholic, they're higher risk for having abuse for opioids. If they have a history of bipolar, they have a higher risk. What was their age of onset of some of these problems or other risk factors? And things we should just think about, especially if I have other options. Now, definitely if we're doing pain management or primary care, that's important. But if I have other options besides opioids, maybe I should consider those in some of these patients, especially if they're at high risk. Don't forget your non-pharm options, especially things like immobilization is really helpful with orthopedic stuff. Cold application. What about virtual reality? Anybody done any work with virtual reality and pain control? One of my doctorate students right now, that's her topic, and I'm interested to see where this goes. The hospital she works at, they actually bought VR equipment, but they never have really used it, and she's going to look at how that impacts and hopefully reduces the use of opioids. I'm kind of interested in that. Maybe we can all try VR. But things like biofeedback and distraction therapy, massage therapy, not that you're going to get most of your nurses to go in there and start rubbing on your patient's back and temples, but that does have some benefit. So don't discount some of the non-opioid things or the non-prescription things that may be beneficial. So most of these pain medicines are quickly absorbed and easily distributed. Some of these are lipid-bound, some of these are not, but most have a pretty quick onset of action. Most are metabolized by the liver, and most either have active metabolites or are not metabolized fully, and the active drug stays bound until they eliminate it. Definitely, if they have some renal dysfunction, like other things, that may prolong the half-life and may give us a longer duration of action. Morphine, we talked about a couple of times. It's our gold standard. Anytime we get a new opioid, it's compared back to morphine to see what its equivalent is. The nice thing about morphine is it's kind of a moderate duration, but look at the dose. For most people, it's somewhere between 0.1 and 0.2 milligrams per kilogram. How good is that 4 milligrams that we always order that's usually the preset in the computer going to be effective? Probably in most people, they're underdosed with morphine. To really get most people good analgesia, they probably need 6, 8, maybe 10 milligrams of morphine to really get the full analgesic effect. But we know that morphine can cause some nausea and vomiting in some people. It definitely can cause hypotension in some people because morphine causes that histamine release. And that's one reason that people don't like morphine or claim it doesn't work well, it's probably because it's underdosed. But if 4 milligrams works, it does. But most time, for most people, they're going to require a higher dose to get the best effect. Meperidine, not commonly used anymore. This is our first synthetic. The big thing about Meperidine is it can cause significant nausea and vomiting. As we talked about earlier, use very cautiously in our elderly people or anybody with renal dysfunction because the buildup of metabolites can lead to seizures. So we rarely use it anymore. Fentanyl definitely is something we use very commonly. The nice thing about fentanyl is it's very potent. It has very minimal, if any, effect on the respiratory drive or the blood pressure unless they're given too much or they already have underlying problems like hypovolemia. Small doses can do pretty well. One of the big concerns is that risk for that rigid chest phenomenon. That's usually seen when people are given large doses very rapidly. And the studies that originally pointed that was actually their neonate studies, and they were giving them large doses in the OR. Most of us probably aren't hitting most people with 200 mics right off the top, so probably that's a low risk. The nice thing about fentanyl is it's short-acting, probably 1 or 2 hours. So I can get a analgesic, but then they can maybe get a better assessment for something post-op or further down the road. As I mentioned, nice IV or also intranasal now. But definitely we've seen significant uses of fentanyl and definitely a significant rise in opioid deaths because a lot of people aren't used to fentanyl. They're maybe used to doing perks or tabs and then realize, ooh, fentanyl's pretty potent. And they get into some of this other stuff like remifentanil and sufentanil. Those are even more potent. And then definitely this is probably our to-go-to in a lot of EDs now for trauma, but definitely be cautious with we're sending people home with stuff, especially like the transdermal patches or the lozenges. And we'll talk about those in just a second. But those transdermal patches are not intended for opioid-naive patients. And probably for most of us, we should not be prescribing these for people going home unless they're a chronic opioid user and they need a refill, but most of us won't refill those. There's several cases out there of people who were given a transdermal patch. They went home and had some bad effects. The transdermal patches take a couple of hours, up to 24, to get the full effect. They usually are rotated every 3 days. If you apply heat to them, they're going to absorb faster. And usually when they rotate these patches off every 3 days, there's still active drug there. So they need to have a organized disposal system where they put it in a Ziploc bag and throw it away. They fold it over on itself and seal it so it's less likely. But, you know, people come in there wearing 4 or 5 of these things. People will try to boil them and get the fentanyl out of them. So these still have active drug in them even when they take them off after 3 days. So hydromorphone, good old Dilaudid, as some of my patients like to call it, it's pretty good, pretty potent. As you notice, the dose is about 0.015 versus 0.1 for morphine. It's a big heavy hitter. It's also one of our big drugs for missed doses because people are used to giving morphine and they, do 4 or 6 milligrams. And they're like, 1 milligram, that's not enough. Let's give them 2. And for a lot of people, 2 milligrams is a lot, and they probably don't need it. This is definitely one that you can titrate, give 0.5, give 1, and that probably here is this image illustrates, think about when your drug peaks. And if just drug peaks in 2 hours, then every 2 hours, let's dose them. And that way we get the stacking effect. And if we don't have that fall off, they tend to get good analgesia, at least for a short period of time. The goal is to try to use non-opioids and maybe augment those with opioids. And there's some good evidence that using a NSAID or acetaminophen with an opioid reduces pain, reduces the need for opioid, and tends to decrease the duration of opioid therapy. Many people are using like IV acetaminophen or IV ibuprofen. Has some benefits. So methadone, and most of us don't prescribe this, and most of us have pretty strong rules in place, either by our hospital or our state about who can prescribe methadone. But methadone is one of our key drugs used for opioid withdrawal or opioid treatment programs. Most of those are what we refer to as the DOT programs. They're going to come in, get their dose every day. Usually it's in a liquid, because that's a lot more difficult to grind up and shoot up. But the big thing about methadone is it has a very long half-life. And a lot of times the analgesic effect goes away before the full effect of the drug does. And we can see some QT prolongation, some other problems with methadone. It is effective, but it also has some long-term problems if it's abused. And then one of those big things is the QT prolongation. As I talked about with a couple other things, it's not usually when they're on the one drug, it's when they're on 2, 3, 4 drugs that affect QT that really get concerned. And then we have our partial agonists that most of us use pretty frequently, like our oxycodone or our hydrocodone. And these are now all Schedule IIs. Most time these are always combined with aspirin or ibuprofen or acetaminophen, and they kind of give you a little bit more bang for the buck. Looking at most of the evidence, there's really no benefit to say that, hey, one's superior to the other one. Some people may have better results with one versus the other. But this is one of the things we have to look for about the acetaminophen concentration. And several years ago, the FDA required no more than 325. You used to get, 500, 750, 500. And so now they've reduced the dose, but making sure patients understand this has acetaminophen in it if you're using that one. So they should be cautious with their extra over-the-counter acetaminophen. What about codeine? For years, we used lots of codeine. We used it a lot in OB, a lot in peds. For codeine to have its biggest analgesic effect, it has to be metabolized to morphine. And what we're seeing a lot of people is they have a polymorphism that either makes them rapid metabolizers or slow metabolizers of codeine. So if they're a rapid metabolizer, they get this rapid conversion over to morphine, and they're at risk for toxicity. And sometimes they're slow metabolizers, and they get very little, if any, analgesic effect. So most of the recommendations say no more should we be using codeine in peds, and probably for adults anyway, because they're going to either get super therapeutic effects or subtherapeutic effects. And for the most part, there's better things out there now. Oxycodone and hydrocodone are both analogs of codeine. Hydrocodone is metabolized to hydromorphone, and oxycodone is metabolized to oxymorphone, just in case you're curious. But they actually get converted over and have active metabolites. And most of our opioids do. That gives them that longer half-life. So Tramadol. This came out, it's like, yeah, this is our answer. It's an opioid-like drug, but it's not an opioid. And the biggest thing is it has most of its effect on our neurotransmitters. It's kind of an analog of codeine, but it has its biggest effect there with norepinephrine and maybe some effect on serotonin. But probably it's not a good drug to use in people who are already on serotonin drugs, if they already have some risks for serotonin syndrome, or they're on maybe an MO inhibitor. It has been known to precipitate withdrawal symptoms in some opioid-dependent patients. It may cause some interaction or other things with drugs that affect serotonin levels or norepi levels. And since it became a scheduled agent, people started using it more like, oh, this must be good, it's scheduled. And looking at some of the studies, it was no more effective than acetaminophen or no more effective than ibuprofen. And then in some studies, it showed it was good for mild to moderate pain. Depends on sometimes the placebo effect and the patient's thought if it's going to work, in my opinion. But definitely understanding it doesn't work like the typical opioids. It has more of that neurotransmitter benefit with a little bit of mu effect. And then our mixed drugs, and we don't see these much anymore. Years ago, saw a lot of pentazocine or a lot of Stadol use. The big thing about these drugs is these have what we refer to as a ceiling effect. The other opioids don't. You give me more morphine, I get more analgesic effect. You give me more hydromorphone, more analgesic effect. These drugs have a ceiling. The more Stadol you give me, you don't increase my analgesic effect. You get my more side effects. So a lot of these were strong kappa and weak mu antagonists. When these first came out, I was like, hey, these are good drugs. We can give them. We can treat their pain, but they don't have that huge addictive property because they're not stimulating mu, they're antagonizing. But they weren't really strong analgesics, and since they blocked mu and then you want to give them a mu agonist, they don't work as well. And what happens if you give one of these to somebody who's opioid dependent or addicted? And when you give them a mu antagonist, they're going to probably have some withdrawal symptoms. And I've had several patients that failed to tell me they were taking certain things, and back when we used to use these, and you give them a good old shot of nalbutine, and about 30 minutes later they start jonesing, and they were not very happy with their withdrawal symptoms. So these were not really good drugs. We still talk about them, still use them occasionally, but buprenorphine is the exception. Well, those other agents are kappa agonists and mu antagonists. Buprenorphine is a partial mu agonist, so it has more analgesic properties. And now it's definitely become one of our mainstays for drug treatment programs, for detox programs, etc. You can give just buprenorphine by itself, or often it's combined with things like naloxone, which usually requires special DEA permission, and you may have to have special training to do those. But buprenorphine is a pretty good pain medicine for acute pain, and definitely is sometimes used instead of methadone with naloxone for pain programs. And probably the nice thing is it does give us that mu effect without a lot of the other significant complications because it's not a full agonist. They get analgesic effect, and then the naloxone is there usually to prevent abuse. Because if you take the naloxone and you swallow it, no big deal. But you decide you're going to snort it or you're going to shoot it up, then you're going to get the systemic effects of naloxone. Very little effect taken orally, very little effect taken buccally. But if you decide you want to try to grind this up and shoot it up, that's when they get the big problem. And there's special formulations out there, and there's a lot of requirements now to get that special endorsement on your DEA license. But definitely a big focus on medication-assisted treatment, the MAT treatment, and trying to help meet the needs of these patients. And a big thing for a lot of us is we may consider, and there's lots of discussion and podcasts about starting MAT in the ED, but who are they going to follow up with? If we're going to give them the option to start this, who are they going to follow up with? If they don't have follow-up, it's not a good option probably for most of us in the ED. Full agonist. Yeah, so it has a very strong affinity, and one thing we'll see if people are on this and they stop it, we need to titrate them back up. You can't just start them back at their full dose, and usually we titrate them up on the buprenorphine. It has a very strong affinity, and if they've stopped it for a couple of days and we're going to restart it, we need to restart it at a lower dose. Otherwise, they're going to get a full effect and have some of that risk for sedation, respiratory depression. And they can go into withdrawals. It can precipitate that for sure. So these tables just kind of give you some comparisons of how these opioids compare to one another, so that, say, 10 milligrams of IV morphine is the same as 100 mics of fentanyl or 1.5 milligrams of hydromorphine. And this is the equivalence chart that we sometimes use if we're doing opioid rotation, but just kind of give you an idea, if you haven't seen this in a while, of how these different agents compare with their efficacy. And definitely shows the different potency out there and what we can do with these. But it's going to take 300 milligrams of Tramadol to get the same effect as 30 milligrams of PO morphine. It's a big dose that exceeds the max daily dose. So definitely has some comparison. Talked about this a little bit earlier, but definitely naloxone's a reversal agent. Now there's lots of auto-injectors out there. Some places with a prescription, some people without a prescription. But the big focus, as we talked about, is to wake up the respiratory drive, but not the full patient in most scenarios. We talked about the half-life is much shorter, and definitely keeping in mind that the half-life is going to wear off before most of our opioids wear off. And most recommendations will be that if we've given naloxone reversal, monitor that patient if possible for at least 2 hours. By then, we know if they're going to have a reduction in mental status or not. Now, a lot of them, unfortunately, will leave AMA as soon as they wake up and because they're mad because you took their fix away. Maybe they're thankful that you saved their life. But probably at least 2 hours for observation before we can discharge those patients safely. All right, so now our non-opioids, our NSAIDs. These are really good drugs. They're very effective at treating pain. They work both centrally and peripherally for prostaglandin inhibition, which is what gives them their big benefit for analgesia, but also is what causes a lot of their side effects. These are going to give us COX-1 and COX-2 inhibition, which is what causes their risk for renal problems. Most of these NSAIDs are going to counteract a lot of antihypertensives, so people that take a lot of NSAIDs tend to increase their blood pressure. Since we inhibit prostaglandin synthesis, we're going to reduce mucosal production in the stomach and the other respiratory tree as well, and that puts that person at increased risk for gastric ulcers. Most all these have antiplatelet effects as well. So we have to be aware of that if we're using these agents. But the nice thing is they do cross the blood-brain barrier, so we get that central effect as well as the peripheral effect. And we do know they kind of have that additive effect and maybe sometimes a synergistic effect with the opioids. So definitely we should avoid NSAIDs in late pregnancy because they can facilitate closure of the ductus. Most people say up until about 37, 36 weeks, they're okay. But definitely at 36 plus weeks, probably no NSAIDs because of that risk. These have some significant side effects like Stevens-Johnson syndrome in some patients, but they're not always there, but definitely one of those things we have to consider and may consider educating the patient about if they start having some blistering or some skin changes, they definitely need to be seen sooner. As I mentioned, they can reduce the effectiveness of a lot of our antihypertensives because they're going to increase vasoconstriction of the renal arteries and increase maybe the outpouring of renin from the kidneys. Ibuprofen is our first one, then we got naproxen. Probably the benefit of naproxen is it's a little bit longer acting, so that instead of having to take it every 8 hours, they can take it every 12 hours. Probably naproxen has less of an impact on the kidneys and the stomach than ibuprofen. And they're both available over the counter, or you can write a prescription for them. Indomethacin probably has the best effect when we're talking about treating things like gout, but any of these NSAIDs are effective in treating gout as well. Ketorolac, parenteral probably is their best thing. Though there are some really good anti-inflammatory now eye drops for pain that work really good for like corneal abrasions, and a lot of times use them for post-eye surgery. But ketorolac is that one drug that the oral dose is usually set at 10 milligrams and no more than 5 days. It's just such a huge hit on the GI mucosa. Some of our more selective NSAIDs, like our COX-2 inhibitors, these are drugs we use commonly for things like osteo or rheumatoid arthritis. And these are either selective or very specific for COX-2. Celebrex, meloxicam, these agents probably have less effect on platelets than anything else. And that's the way we like if people need chronic care for osteo or something else, they use one of these agents. They're usually once a day, and they are restricted usually just to COX-2, which can sometimes give some of those kidney problems or ulcer problems, but definitely have less effect on the platelets. And most will say that Celebrex has really no effect on platelets. So it might be a good option for that patient who needs some anti-inflammatories, but is already on antiplatelets or anticoagulants. But the NSAIDs have a big black box warning that all non-acetylated NSAIDs, that excludes aspirin, it's the only one that is acetylated, but all these non-acetylated NSAIDs have been shown to increase the risk of cardiovascular problems, especially thrombotic events in some patients, and all have been associated with the risk of GI bleeding. So definitely we use those, we need to be cognizant of it. Does this patient who's a high risk already need to go on an H2 blocker or a PPI for a couple of days while they're doing their course of NSAIDs? That may be beneficial, but definitely thinking about talking with the patient and increasing their knowledge may help us avoid any complications if this were to come up. Because NSAIDs play a good role, usually for short-term therapy, especially in the elderly or those who already have hypertension, but educating the patient or maybe taking that proaction. And let's go ahead and do an H2 blocker for a couple of days while you're on this, just to lessen the risk of a GI bleed. So acetaminophen. Acetaminophen is also going to have antiprostaglandin effects, but it only works centrally. It doesn't have that peripheral effect that we see with the NSAIDs. Several formulations out there now. We can give it IV, we can give it by mouth, but definitely there's some benefit to doing intravenous. So as you see here, depending on where you work, that's pretty inexpensive. But then I've heard people go, oh my gosh, the hospital won't let us use it. They say it's really expensive. IV acetaminophen is not that expensive. About $30 a dose is what the hospital pays for it. Now, I don't know what they charge the patient, but it's fairly inexpensive, and there's some good evidence, and anecdotally I can say that I've seen patients that you give it to, and they're like, wow, that was really good. What'd you give me? IV Tylenol. And they like freak out because they didn't believe it. But there is some benefit to giving IV NSAIDs or IV acetaminophen with a small dose of opioid, and they may have that synergistic effect. As we mentioned earlier, the max dose currently recommended by the FDA is no more than 3 grams per day. That is well below the toxic level, but increases or decreases the risk for toxicity, especially if people don't read labels. Acetaminophen is considered the first-line agent for osteoarthritis. Great board question. But it's usually helpful. And they can alternate ibuprofen, acetaminophen, alternate ibuprofen and naproxen, and they work differently. And there's even some thought that maybe acetaminophen has an effect on the cannabinoid receptors that may play with some of its analgesic effects as well. Our topical anesthetics that we have available, and we use these for certain things. The biggest thing about most of these topicals is they're not as effective if the skin's intact. So things like lead or TAC or LET or whichever formulation you use, they work really good if there's broken skin. So these mixtures of lidocaine and epi and tetracaine, or maybe it's cocaine instead, those work really good on lacerations, especially if you want to numb up the area before you inject and infiltrate with an anesthetic. But on intact skin, they're not as effective. And I mentioned earlier, I think it was New England Journal I just saw, there was an article that talked about that probably dripping a little bit of the anesthetic on the skin before you inject has been shown to reduce the pain. Okay, we'll try that next time. I haven't done it yet. But some of these are better acting than others. The nice thing about the TAC, using the cocaine is a vasoconstrictor, so it's going to prolong the anesthetic effect, but also has some good anesthetic properties as well. It's really good, especially if you're having to do ENT procedures. And we'll talk about some of those in the next couple of days, but if you're having to do some nasal stuff, topical cocaine, your supply, not the patient's, may have some benefit. Because sometimes they want to bring their own supply. What about infants? What about high-dose sucrose? These sweeties or these high concentration. And in a lot of places we may use this as an anesthetic or an analgesic, I should say, before a lumbar puncture, before a painful procedure. There's even been a big push before vaccines. So giving 1 or 2 doses of this has been shown to have a euphoric effect. It probably enhances or increases our endogenous opioid release. The big concern is if I use a lot of it, you got to worry about hyperglycemia because it is 25% sucrose. It's a pretty good amount. But a one-time use probably is going to be helpful. Put it on the pacifier, put it on the nipple, on the finger, and let the kid just suck on it. It tends to have some benefit. And then lastly, our migraine stuff. So for years, we had options like the ergots. And the ergots were fairly effective at treating migraines because they have multiple benefits, especially here with dopamine and serotonin. They cause vasoconstriction, and probably most migraines related to vasodilation. But you couldn't use these within 24 hours of a triptan. These were probably contraindicated in most people with ischemic heart disease, with hypertension. It is a category X. But these are really good. Ergotamine, which is Cafragot, usually combined with caffeine to increase the absorption, was effective. Probably DHE is a little bit more effective and has a little bit safer profile. But if somebody has significant cardiovascular disease, these are not good options because of their vasoconstriction. Talking about what's going to help differentiate our different types of pain. Usually your migraine patient has that unilateral, sometimes bilateral. Usually it's that throbbing pain, that pulsating pain. Where your tension headache is usually non-throbbing, non-pulsating. I think Greg's going to talk about headaches tomorrow. But there for a while, ergots were an option that we might consider, but probably not the mainstay anymore. And now looking at the literature, they consider the triptans to be the first-line agents for treating a migraine headache. Some benefits, some side effects, but probably most people, their migraine is related to either vasodilation or activation of the trigeminal nerve. So probably one of these triptans is going to help calm down that trigeminal nerve and help with some of the pain transmission. The nice thing is about these different agents that are out there, they work on different sub-receptors. So if we've tried one agent and the patient's tried one agent, it didn't work, another agent might work. So if they say, well, I've used that, it didn't work, then maybe we could try another one. They're not all going to work the same because they all work on different subunits of the serotonin receptors. These tend to be still contraindicated if somebody has significant cardiovascular disease, uncontrolled problems like hypertension. They cannot have recently been taking an ergot or an MAO inhibitor. There's several precautions listed for you here. Some of these are now considered safe and effective in pregnancy. Some are considered not to be used. Since these do deal with serotonin, are they safe with SSRIs? Probably in most patients, but something we have to be aware of. Some of the common side effects we see, flushing and chest discomfort is one of the big ones. They usually will have a little chest tightness, a little chest discomfort, but it goes away in a couple of minutes. But they may have some dizziness, some nausea, but usually they're very short-lived, and some more significant than others. So how effective are triptans at treating migraines? This was a composite looking at a lot of different studies out there, and that found that it got decent relief in 2 hours, moderate relief after 24 hours, but definitely it was a better outcome when this was combined with something else. And the addition of an oral NSAID or acetaminophen actually gave better results at 2 hours. So probably go ahead and give them a dose of naproxen, and their triptan may give us faster onset of relief and may give us better overall pain control. Probably for most of us, Imitrex, sumatriptan is the one we go to first, but it's a sub-Q injection, and some people don't like the shots. But usually we think about cardiac monitoring because they sometimes can get some palpitations, some chest discomfort. But they've also compared us to other things we'll talk about in a minute, like prochlorperazine and metoclopramide, and they're probably just as equally effective. They were not inferior to each other. So Zomig is the one that's out there that actually is available as an OTT, and some people may use this prophylactically at home, or we may have the option to give it there in the ED. It even comes in a transdermal patch that we'll sometimes see used, a nasal spray. But different things are out there, and if one doesn't work, we can try another one. But usually most people don't like the side effects of the flushing, the palpitations, but it goes away pretty quickly. So what a lot of us have found, and definitely one of my favorites, is the dopamine antagonists. Droperidol was really good for treating migraines. It gave us some pretty good benefit, but it's got that black box warning for arrhythmias, and you can't get it anymore. So what most of us have access to is usually either prochlorperazine or metoclopramide. As we talked about earlier, that probably those are very effective, but they should be given as IV piggybacks and not as a push. That if somebody just walks in and hits them with 10 right off the bat, they're probably going to not like the effects. But if we give it to it as a slow infusion, probably going to have much better. We can pre-dose with diphenhydramine, which may help reduce the risk of dyskinesias, and most of us have our little cocktail, maybe some Toradol, maybe some Compazine, maybe some Benadryl. But looking at a couple of studies, that risk of dystonia may not be so significant. And this was in 16, but they looked at, do we really need diphenhydramine or not? And they found that there was really no significant difference in people who got diphenhydramine versus got the placebo with their dose of their antagonists. And so that definitely we don't see a significant change there. Oh, too fast. And that probably most patients are going to have just the same effect. And what most of the recommendations are, if they're starting to have dystonias, then give them the Benadryl. Otherwise, don't give it to them. But the biggest thing is how fast they get it. Is it IV piggyback over a couple of minutes, or is somebody just slamming it into them? So there's been several studies that compared things like prochlorperazine and sumatriptan, which was more effective, which had more side effects, and kind of gave you some of these results. But we got pretty good results here and found that, prochlorperazine was non-inferior to sumatriptan and other things and giving us some significant benefit. So in people that are really worried about the cardiovascular risk, that probably a dose of IV Compazine or a dose of metoclopramide is going to be just as effective. And even a couple studies that compared these two as well. So definitely we have several options in our toolkit for treating migraines. If they don't like one thing, maybe we can try something else. What about a good old Haldol? Since we don't have droperidol anymore, is Haldol safe? And looking at this study, it was. That we had very little risk of complications, that Haldol probably gives us some good benefit, gives us that dopamine antagonist effect, which is what we want. And looking at this, those people required less rescue doses, and it was more effective than metoclopramide. So some other considerations and what some people do is definitely these cervical injections of bupivacaine. And your patient that's allergic to everything, they're allergic to Reglan, they're allergic to Compazine, then what about some Zyprexa? It's an anti-dopamine agent just like all the others. And that definitely if we don't want to use Haldol, we don't have droperidol, then maybe some olanzapine will be a good option. And actually it's been shown in several studies to be just as effective and usually also causes sedation, so they sleep well and they feel better. But definitely we've got several tools out there in our tool chest, especially for all those people because they want an opioid, but we know opioids don't help migraines. They hide the symptoms, but the migraine or the pain is still there. So we'd focus on something that's going to affect the stuff, and that definitely one of their anti-dopamine agents are going to be most effective. What about steroids? Many people follow up their migraine patient with a dose of dexamethasone. And there are several studies that have shown that giving a dose of Dex, 10 milligrams, is going to help limit the reoccurrence of that migraine and may give them longer pain-free time. So I tend to go ahead and give people, unless I'm worried about diabetes or other things, and give them a dose of Dex, and it tends to help reduce their reoccurrence. And for most truly migraine sufferers, they're happy not to have this come back in 12 or 24 hours. In our use of local anesthetics, a lot of things can easily be treated with regional blocks. Finger dislocations, finger amputations, really good to really go in there and do, whether you do a ring block or the interthecal block, but use those agents. What about for dental problems? Many people like to do dental blocks, whether we're doing just a periapical block or do true dental blocks. And now they're pain-free for several hours. And if somebody truly is having pain, they're usually very thankful because now you've given them some good pain relief, and these are non-narcotic options. So now I can treat their pain for several hours until we can get them in to see a dental provider. And also go ahead and supplement that with some non-opioid oral agents, some acetaminophen, some NSAID will also help as well. There's several things that we can anesthetize and give us a great benefit. We definitely know that anesthetics tend to burn when they go in, so probably injecting slower with a smaller needle is going to help reduce that. We can add some sodium bicarbonate to it. That'll adjust the pH so it's not as acidic and doesn't burn as bad. You can also add epinephrine, or it usually comes pre-added. But the nice thing about that epi is it prolongs the duration because of the vasoconstriction. And for years it was like, oh my gosh, don't put epi in the fingers and the toes and all that stuff because it might cause an ischemia. Most of the new evidence says it's fine. And that probably go ahead and injecting lidocaine with epi or marking with epi in a digit is going to give us longer duration of effect without any increased complication. And we'll talk about some of this in the next couple of days. Probably ears, I'm not really probably going to inject those with lidocaine with epi, but definitely the digits, they've got great circulation. Unless this person just a vasculopath, probably most of the literature showed it's going to be fine. As we talked about earlier, lidocaine is a CNS depressant, so we sometimes can cause toxicity. And definitely the person that starts having tinnitus, the person that starts seizing, we do have to worry about potentially toxicity. And then definitely we talk about people that have these lidocaine or these Novocaine allergies, and we look at the different types. So like the amides, which is their lidocaine, is not what Novocaine was. So if they're allergic to Novocaine, which actually is an ester, that is probably not going to give them a cross reaction to lidocaine. But if we can inject them with a local anesthetic, any other options for injection that may help reduce pain? If you look at some of the wound care books, they actually talk about injecting diphenhydramine, Benadryl. So diluting Benadryl, injecting it in the tissues will also give a local anesthetic effect, but it's going to hurt real bad initially. Never had to use it, but that's a backup option. If we can't inject with lidocaine or bupivacaine, then we can use a diluted diphenhydramine. But supposedly it's really painful. And that brings us to the end. We have finished 8 hours of pharmacology for EM and hopefully gave you some new insights, hopefully refreshed you on some stuff. Hopefully this was beneficial and you found this educational and didn't feel boring that you were sitting here talking about pharm for 8 hours. We're going to enhance upon this the next 3.5 days and talk about the pathophysiology and the treatment of all these conditions. Any questions? Yes, sir. Okay. Yeah, I wonder, since it's a nasal, if the significance is there for the cardiovascular concerns. I'd have to do some research, but may not be as bad with intranasal ergotamines as the systemic ones. But the big concern was you could get so much cardiovascular stimulation you could actually cause a coronary event or a hypertensive event. And now some people are using Botox. And actually now there's also a monoclonal antibody for treating migraines as well. That just recently has been a hot topic. Okay, good. Wow, that's impressive. Thank you. Any other questions? I don't know if Rick has anything he wants to say or not. That's a good question. I know they have specific criteria that has to be met, and we didn't look at that for the MAT stuff, so I'm not sure. We'd have to look at it and see. We can check. But that was about meeting the criteria for the medication assisted and actually getting that endorsement under DEA. So the question was about the recommendation for the Decadron. I'm not aware that they've looked at prednisone. They just looked at dexamethasone, but we know that looking at other things, dex and prednisone are equally effective in treating inflammatory conditions. So probably giving a dose of oral prednisone is going to be just as effective, but I don't think that any of the studies have looked at it. It's all been looking at dexamethasone. 10 milligrams. And dex tends to have a little longer duration, so you probably get at least a day, if not 2 days of benefit. Yes, so the corticosteroids is in addition to, so if you choose to use clocoperazine or metoclopramide, and then they get relief, then give them the 10 milligrams of IV piggyback dex, and that's been shown to reduce the reoccurrence. So I usually give them my clocoperazine or my Reglan, and then go ahead and get the dex ordered, and it comes as a piggyback. And it tends to work. Some people, it may take a little bit longer, but usually that gets the benefit. All right, thank you all very much. Enjoy it. We'll see you the next 3 days.